Hi, everyone. I'm Carolyn Cuttino, and I'm a certified wound care nurse at the Medical University of South Carolina in Charleston, South Carolina, and I'd like to welcome you to today's webinar on heel pressure ulcers. I would also like to thank DM Systems for their support for this webinar and HMP for their technological and marketing assistance. I'd also like to thank you, the audience, for being here and participating in today's program. Your participation is really an example of how we strive each day to reach our goal of decreasing pressure ulcers in our facilities. So welcome to today's webinar on heel pressure ulcers, your journey towards zero prevalence. Today we're going to look at several issues. We're going to identify patients who are at risk for development of heel pressure ulcers. We'll examine the connection between TED Hose and heel pressure ulcers and the implications for our practice. We'll also describe what these heel ulcers may look like or their clinical presentation, and we'll explore interventions and strategies that you might want to consider in your heel pressure ulcer prevention protocols. We'll also examine some legal concerns surrounding pressure ulcers, and then lastly, describe the role that each staff member must assume in the prevention of pressure ulcers. So, when we look at heel pressure ulcer statistics, in acute care you see that heel pressure ulcers represent about 1/3 of all pressure ulcers. We see a high prevalence of heel pressure ulcers in our critical care units as well as in our orthopedic populations also. Also in acute care, those people who are having some type of OR procedure will develop perioperative ulcers, and there's been as high as 23% incidence reported, and over 50% of those were heel ulcers. In long-term care, prevalence for pressure ulcers has been documented as high as 27%, and 23% of those were heel ulcers. So as you can see, heel pressure ulcers are a big problem in all sites of service. So let's take a look at why the prevalence is so high. Why is the heel ulcer or the heel location the most common location that we'll see an ulcer in those residents in long-term care, and the second most common location overall, second only to the sacral ulcer? Well, as you can see in this picture, you see a very large heel or calcaneus bone. There's really minimal subcutaneous tissue covering that bone. There's really no muscle to dissipate the pressure. You see a decreased blood flow, and when the patient is supine, the weight of the foot or the leg is really concentrated in a very small area, and with minimal subcu tissue there and no muscle to dissipate the pressure, you can see why the heel is really an ulcer waiting to happen. So who is at risk to develop these heel pressure ulcers? We know that diabetics are 4 times more likely to develop a heel pressure ulcer. People with poor perfusion or PVD or PAD, those who are malnourished or dehydrated, people who are immobilized or have impaired transfer for various reasons, maybe it's a hip fracture or they're comatose or are spinal cord injury patients, they're all at risk for heel pressure ulcer, as is the elderly, those people with end-stage diseases, also those who might have decreased sensation, and that might be from anesthesia or some type of neuropathy. There are also some special populations that we need to think about who might be at risk to develop a heel pressure ulcer. Our ICU patients, they may have been on vasopressors or on an intra-aortic balloon pump, or maybe just because they've been restrained on ventilators. But as you can see at these two, the top and the middle picture here, this was a gentleman who was on a vasopressor. You see the ischemic areas on the toes, and you also can see a dark ischemic area on the heel. Well, because of the location, this is going to be documented as a heel pressure ulcer, whereas the toes may be defined or documented as an arterial or an ischemic wound, whereas they happened at exactly the same time on exactly the same patient, and the patient was on a vasopressor. And this is why I urge you, when you're doing your assessment and documentation, to make sure you're including any risk factor that might be present, and also to make sure you're identifying that they are at risk and have some type of preventive protocol in place to prevent this heel ulcer from occurring if possible. For those of you who work in long-term care, think about the residents who come in with foot deformities. They may be wearing shoes that are too tight or that are rubbing on the foot that might be causing some type of skin problem or skin breakdown. Think about that resident who's propelling themselves through the facility in that wheelchair. And this bottom slide is an indication that this is exactly what happened. This was a gentleman who was diabetic. He had some PAD. Also, he had some shoes, tight shoes on, and he propelled himself throughout the facility, and this is the outcome there. So we have to think about that. Also think about the residents that might be bedbound with contractures, that their heels are really digging into the bed surface. And you can see why these are special populations that we need to be concerned with. Another category of patient that we mentioned earlier was that perioperative ulcer, the surgical patient. And these next statements really are about pressure ulcer development in general. But we know that people who have a prolonged OR time are at risk to develop a heel pressure ulcer. Every 30 minutes over 4 hours will increase the risk by 33%. Patients who have multiple OR procedures because they have a prolonged period of immobilization or a prolonged period of sedation. OR patients who require vasopressors or patients who require surgery that are malnourished, would have a low BMI. Those patients who have a high mortality risk, those with diabetes, all of these patients are more at risk to develop a pressure ulcer. And remember, as we said earlier, that over half of the perioperative ulcers were on the heel. Another risk factor or another group of patients that sometimes we don't think about as being at risk to develop heel ulcers are those who require TED hose or graduated compression stockings. We use these, of course, to prevent deep vein thrombosis. However, before routine orders are implemented, I think there's some critical thinking that we need to do. We have to realize that when we apply a TED hose, that the compression that we're adding is automatically adding about 18 to 20 millimeters of mercury pressure to an already compromised area. And when we add to that other comorbidities like that vasopressor that we mentioned, or the malnourished patient, or the patient who has diabetes that might have small vessel or large vessel disease impacting perfusion, you can see how the risk for breakdown will increase greatly. Some literature suggests that patients with diabetes, PBD, and atherosclerosis are at risk of skin breakdown with TED hose. And this is why they recommend frequent remeasuring when the patient might complain of tightness or swelling. And also, I think we have to remember here that many times the people that we're putting these stockings on, they may have a decreased sensation, so they may not even feel when it's too tight or when they have pain. And also, they might not be able to communicate. Think of that stroke patient that comes in that's going to be immobilized that we might automatically put a TED hose on, and they are not going to be able to communicate that it's too tight or they're feeling pain. So we have to think about that. Literature also suggests that patients that might have cardiac failure, pulmonary edema, and even a sensitivity to the stocking fabric can increase the risk for heel pressure ulcers. Some of the problems that I've identified, and I'm sure that many of you can add things to this list, are that sometimes they're just put on wrong. They don't fit correctly. They're not sized correctly, and they're either too tight or maybe they're so loose they're hanging around the ankles. I find that they're not taken off routinely for assessments to be done, and they're hard to get on and get off, and maybe that's why they're not taken off routinely. But basically, I really believe sometimes TED hose can really hide the evidence. And how many times have you taken a TED hose off and seen an ulcer on the heel or the toes that have not been reported before? A survey was done among nurses that was published that looked at some problems with TED hose, and these are some things that came out of that survey. Many nurses stated that they never measured the legs before applying the TED hose. They found that the correct size was not always available, and you know that your central supply or materials management may only want to stock 2 or 3 sizes of TED hose, and you have to use those for every body shape, every leg size, and you know that that's just not feasible. Only 33% of the nurses actually reported taking off the TED hose to do an assessment. They did state that they were assumed that the CNA did. Documentation revealed that circulation checks were not done many times, and of course they found that many patients were just not compliant with wearing the TED hose. So as you can see, we've got some inherent problems with the TED hose to begin with. And this next slide just demonstrates what I'm talking about. This was a patient who was admitted to a hospital. He had a stroke. He was also diabetic, and he had TED hoses that were applied. And you can see the results of this with the skin ulcers on the anterior part of this leg, the ankle area, and also the heel area. And several weeks after this slide was taken, an amputation was done. And this just demonstrates how we have to be very careful with the TED hose that we're using on many patients that we are caring for. So how does this, what kind of implications do we see for practice regarding TED hose? And I really do think if someone needs a TED hose, that we might want to consider a open heel compression stocking. And HeelSafe by DM Systems, they will provide us the opportunity to use an open heel stocking. And you can see where this would automatically remove 15 to 20 millimeters of pressure at that compromised area that we talked about. You can see where you can see easy visualization and easy palpation to do a very good assessment of the heel. The material is also pretty stretchy, and it makes it easier to apply and to remove, and at the same time you're getting that anti-embolic protection that you need. So I really do consider this open heel stocking a very good option to consider, especially on those high-risk patients that we talked about. Some other implications for practice, I really do think we need to think about doing routine audits to make sure the staff is compliant with appropriate interventions and assessments, the things that we mentioned earlier. Are we measuring? Do they have the correct size on? Is the stocking being removed for circulation checks and skin assessments to be done? Are they put on correctly, and is the patient compliant? So in general, I think we just have to remember that graduated compression stockings really might not be the low-risk intervention once thought. And I think before routine application, the issues that we discussed really need to be addressed. And I really just want to increase the awareness that certain patients may not be candidates for this therapy, those with diabetes, those with PVD. But if you need them, I think that when we're doing our assessments and we talk about frequent removal, these are the patients that might need more than the daily removal. They might need the every 8-hour removal to do the assessments and skin checks. So these are the things we need to think about. And just to remember that really all users of TED hose are really at higher risk for heel pressure ulcer development. So let's take a look at what some of these heel ulcers may look like. This is an example of a stage 1 heel ulcer. You see that the epidermis is intact. There's a non-blanchable erythema or redness. The area could be painful, firm, soft, warmer, or cooler compared to adjacent tissue. And as you know, this is going to be difficult to identify in darkly pigmented skin. That's why we have to do really when we're trying to identify that stage 1 ulcer. A stage 2 heel ulcer will be a partial thickness wound or partial thickness skin loss. You will have exposed dermis, exposed pink or red dermal tissue. It will be a shiny or dry, shallow ulcer with minimal exudate usually, as I mentioned earlier, a pink or red wound bed. There will not be necrotic slough or any necrotic eschar in a stage 2 wound. And as you see, as on the right, you might have a closed or intact serum-filled blister, which would be classified as a stage 2 heel ulcer. A stage 3 ulcer would be a full-thickness wound with tissue damage that extends below the dermis into or exposing the subcutaneous tissue. No tendon or bone exposed, but as you can see in these pictures, you may have some necrotic tissue present. This would be the stage 3. A stage 4 is, again, a full thickness tissue loss. You may have exposed muscle or bone, tendon might be involved, and necrotic tissue can certainly be present. As we mentioned earlier, there's no muscle over the calcaneus bone, so you should always make sure that you're either probing or feeling to really assess is there bony involvement, because of course, if there is, we know that we have to rule out osteomyelitis and treat accordingly if we want to heal that wound. But this is representative of a stage 4. Another ulcer might look like this, and this is what we would term unstageable. And it's unstageable because we can't visualize the depth because it's covered with slough, that necrotic yellow slough, or that necrotic black leathery eschar that's well adhered to the wound bed, but this would be an unstageable pressure ulcer. The next stage would be something that we call deep tissue injury. If you're in long-term care, you might call this unstageable secondary to deep tissue injury. If you're in an acute care setting or home care, you might just call it suspected deep tissue injury. But it's a purple or maroon area with intact epidermis, as you can see here. The epidermis is intact, but you see that discolored dark purple or maroon tissue underneath. It could be a blood-filled blister, and the evolution may include blistering that could occur and then a thin layer of eschar that would cover this wound. So right now, this would be termed a deep tissue injury, and when the eschar develops, it would be termed unstageable. So now let's look at some interventions for heel ulcer prevention and treatment. The main thing to remember is we must suspend the heel. And please know that all at-risk patients need pressure relief, or what we call offloading of the heel. The National Pressure Ulcer Advisory Panel, or the NPUAP, in conjunction with the European National Pressure Ulcer Advisory Panel in 2009, published their Pressure Ulcer Prevention and Treatment Clinical Practice Guidelines. And if you don't have these, I would urge you to go to NPUAP.org, again, NPUAP.org, and get a copy of these guidelines. These are the things that you need to incorporate into your policies and procedures as far as what the evidence-based care is for prevention of pressure ulcers. So some statements from those guidelines about heel ulcers are as follows. They stated that most severe pressure ulcers are found on the sacrum or heels, and we've already discussed that. They told us that we needed to ensure that heels are free of the bed surface. No support surface will completely redistribute the pressure over the heel, so you can't rely on that specialty bed or that rental service or any kind of bed surface to manage heel pressure. They also mentioned that heel protection devices should elevate the heel in a way that completely supports the calf weight without pressure on the Achilles area or the popliteal vessel, because you don't want to interfere with perfusion to the lower leg and foot. So that's why they will recommend that the knee is flexed slightly. So these are some things that we need to think about from the NPUAP. The National Pressure Ulcer Advisory Panel, their guidelines also state for prevention and treatment of stage 1 and 2 ulcers that we have to float the heels off the bed by using a pillow, as you can see in the slide on the left. The heel is completely suspended off the bed, or we can use a pressure-reducing device, and this is an example of the heel lift, and you can see again the heel is completely suspended. There's no pressure. It is completely offloaded with this device. For the treatment of stage 3, stage 4, or that unstageable wound or the DTI, the guidelines say to place the leg in a device that elevates the heel from the bed surface, so you're making sure that you're completely offloading. That we have to make sure we check this device frequently to make sure it's being used properly, especially in patients who have decreased sensation or decreased perfusion or edema. We need to remove the device frequently to reassess the skin. And they also state, and this is very important, that pillows are inadequate for these ulcers. So for your stage 3, 4 unstageable or wounds or deep tissue injury ulcers, just know that you need some type of heel offloading device, because these are going to be long-term wounds, and you need a device that's going to make sure that we're completely offloading, and one that keeps the foot in correct anatomical position to prevent foot drop. Some other issues that we need to consider in selecting a heel offloading device is something that's going to prevent rotation of the leg, as I said, to keep it in correct anatomical position, something to manage temperature and moisture. How easy is it to clean? Does it prevent pressure on other areas of the leg or foot? How stable is the device? Does it keep the foot positioned regardless if the patient's moving around or they're non-compliant with keeping the heels and the feet in the right location? Is the correct size used? It has to be easy to use. I've often said it has to be a no-brainer. I want somebody to go into the room, see the heel device, and be able to put it on correctly and not having to worry about that it was put on wrong, that could cause a problem. It's got to be comfortable, or the patient's not going to be compliant with wearing it. And, of course, in this day and age, cost is always a consideration. So those are some other things that we need to think about. So let's look at some options we might have. We mentioned pillows could be used for prevention or for stage 1 or 2, but they weren't adequate for stage 3, 4, unstageable, or the DTI ulcer. Benefits to pillows, low cost, and they are pretty available. But some problems also exist with pillows, because sometimes I walk into a patient's room and they might be using pillows, but the heel is really not offloaded. As you can see in this slide on your left, this lady, she looks pretty comfortable here, but the heel is certainly not offloaded. The heel is certainly not protected because it's in contact with the pillow and the bed surface. And the picture on the right really demonstrates another problem with pillows, in that depending on how big they are, their fill, or their conformability, these pillows will flatten out, and eventually the heel will come in contact with the bed surface. And as you can see, this is exactly what's happened here with the ulcer that is on the heel surface, even because it's in contact with the bed. Some other problems with pillows are demonstrated with these pictures. You see how this foot is certainly not in the correct anatomical position. We've got a shortening of the Achilles tendon here. I'm sure we've got foot drop. We've got a rotation of the leg. And even though the pillow is underneath the heel, you see the heel is still in contact with the bed, putting pressure on that area. And you can see the last slide on your right, I guarantee you we're going to have some issues on the tops of those toes because of the bed. So pillows can also have some problems. When we look at some options, again, with heel offloading devices, one thing I would like for you to know is they are not all the same. Many times what people might call an offloading device is really just a heel padding device. And you have to know that these do not relieve pressure. I see things documented like bunny boots or booties or padded socks or gauze padding is put on the heel or sheepskin or foam dressing. Now, these all might protect from shear or from friction, but none of these are going to relieve pressure. So please know that bunny boots and socks and these kinds of things are not adequate heel offloading devices. The heel must be suspended if we're going to truly relieve pressure. A very good or an appropriate heel offloading device is going to reduce friction, shear, and pressure. It's going to separate and protect the ankle. It's going to stay in place and suspend the heel even when the patient is moving around. And it's also going to protect against foot drop. You've got some options of foam devices, air-based devices, and pillow-based devices. And this slide just demonstrates some of those. As you see on your left, the air-based device. The middle slides are your foam-based or your heel lift device. And again, as you can see, the heel is completely offloaded and the foot is in a very good anatomical position. And then the picture on your right is a pillow-based device. But regardless of how good those devices are, they must be used correctly. We have to make sure that we're checking the straps to make sure they're not too tight and it fits correctly and it's not rubbing on the patient's skin. And they're certainly not going to do any good in the closet or on the trash can, as you see here. And also they must be on the patient. If they don't fit correctly and the patient's foot can come out, then we're not going to get the heel suspension or the heel offloading that we need. So this is why we have, no matter what device we're using, we have to make sure we're monitoring it and doing frequent skin assessments. I mentioned earlier that cost was always an issue, and this cost data is from 2007 from the Centers for Medicare and Medicaid Services, and they said that over $13 billion were associated with hospital-acquired heel pressure ulcers. That's $13 billion. There have been numerous publications also that discuss the cost of heel pressure ulcers, and I've seen things like $2,000 to $3,000 for the treatment of a stage 1 or stage 2 ulcer, and $45,000 up to maybe $70,000 for stage 3 or 4 ulcers, depending on if an amputation was required. And you can't really forget what it costs every facility if someone brings a case or has some type of litigation against them because of a pressure ulcer. There's also been numerous publications that discuss cost savings when a heel offloading device is used for prevention. And this is something that's very important that we have to think about. And different literature sources, they quote several thousands to several $millions being saved, depending on what state you lived in, the number of patients or discharges in your facility, and, of course, your prevalence and incidence data. I would just bring your attention to this website that I have listed for you and urge you to go on and look at this cost calculator information. You can plug in your own facility's data and see the potential costs and cost savings if you utilize a heel offloading device. And when we look at cost, you really can't forget that the cost that you're looking at in your facility is just really a fraction of the total cost when we look at healing to healing an ulcer that might develop. We have to think about not only what it's costing your facility, but what is that insurance carrier or Medicare, Medicaid paying? What's it costing another agency if they're discharged, if they go to a long-term care facility or an LTAC or to a home care agency? What does it cost the family? So the total cost to healing really has to be considered. And as you know, it can be very, very expensive. So this is why we want to try to prevent. Now, what about prevention protocols for heel pressure ulcers? What does the evidence show, and do they work? We know that evidence demonstrates that a comprehensive prevention program can reduce heel pressure ulcers. This was a study that was done in a 500-bed long-term care facility, and they showed a 95% reduction in heel pressure ulcers at a projected cost savings of $12,000 to $1 million. The interventions that they used, a device for heel suspension, I think it was applied within 1 hour of admission to the facility. Assessments were done every 8 hours by the staff. They did staff education, and they applied a skin moisturizer to intact heels daily. And as you can see, these look like fairly easy things to accomplish when we talk about saving up to $1 million for your facility. Another study that was done was a poster presentation that was presented at the NPUAP meeting in 2005. And this was data on from a 500-plus bed hospital system. And they had an IT link to automatic orders for foam-based boots, and it was the heel lift that this particular study looked at, and a WOCN consult for all ventilator or hemodialysis patients. What they found was patients who were on ventilators or had end-stage renal disease had a high incidence of pressure ulcers or heel pressure ulcers in their facility. So when an order for hemodialysis or a ventilator was put into effect, it automatically generated an order for a WOCN consult and for materials management to send a foam-based heel lift boot to the facility, to the patient. And the results were that heel ulcers decreased by 66%, from 63 to 23% after 16 months. So I ask you, do you know who your high-risk heel ulcer patients are? If so, you might want to think about doing something like this in your facility. Another study was done, a random controlled trial that was done to determine the effect of a heel elevation device in pressure ulcer prevention in post-hip fracture patients. So what they did is they had 239 elderly patients who had had hip fractures. They were either put on just a pressure redistribution surface or a pressure redistribution surface and a heel offloading device. And the results of this study, that of the patients who were in the control group or just the pressure redistribution surface only, 31 of 119 patients developed pressure ulcers, and 29 of those 31 ulcers were on the heel, the ankle, or the foot. Whereas the intervention group, they had the surface and the heel offloading device, 8 of the 120 patients developed a pressure ulcer, but none of the ulcers were located on the ankle, the foot, or the heel. And to me, that just reiterates the NPUAP Guidelines statement about surfaces or special mattresses do not protect heels. And also it speaks to the efficacy of using a heel offloading device in conjunction with your surface if we're really going to prevent these wounds from occurring. So our implication for practice is that heel pressure ulcer protocols do work, so use them. If feasible, use your IT or electronic medical record for automatic hold heel offloading device orders for those people that you found to be high risk in your facility. It might be the people in your critical care units, or it might be those on dialysis, or it might be those patients who have long OR cases. Make sure we're doing frequent assessment of the heels. Daily moisturizers to intact heels was another intervention that was used. Making sure, again, we're using the heel offloading device in conjunction with your pressure redistribution mattress. And don't forget, those people who need TED hose need special consideration in your protocols. Well, now let's kind of switch gears and look at some legal implications that you might want to think about or consider for pressure ulcers in general. The legal system believes that if you accept a patient into your facility, you're saying that you can provide care and services that really meet the standard of care. We will be looking at what would a reasonable, prudent provider or facility do to prevent a heel ulcer from occurring, and if one does occur, did the facility deviate from the standard of care? So what is the standard of care? Well, basically, we're looking at those guidelines from the National Pressure Ulcer Advisory Panel that we already discussed. I said this is, even though they're not considered the standard of care, they're the guidelines that we look at for evidence-based care on what we should be doing to prevent wounds and to manage wounds. And I'm not going to discuss them again because we've already discussed what they were, what some of them were. But they'll also be looking at your facility policies. And again, your policies should not be written in stone. They should not be standards of care, so to speak, but they should just be guidelines for the clinician to use. And I encourage you to be careful with specifics in your policies or guidelines, and don't use terms like every, always, never. I would never say, like abnormal lab results need to be reported immediately, all right? Don't take away the clinician's critical thinking or ability to plan and direct care based on the individual patient's needs. I would also encourage you to be careful with assigning responsibilities outside a staff member's scope of practice. Many times I see an LPN that might be assigned the job of doing the wound assessment in a long-term care facility, whereas in most states, pressure ulcer assessments cannot be done independently by an LPN. An assessment is the scope of practice of a registered nurse. So don't put your LPN in that situation. So be careful with what your staff member's scope of practice is. When we're looking at standards of care, also we are looking at what are the CMS regulations, especially in long-term care. They have said that a pressure ulcer development is a medical error and a sentinel event in low-risk patients, and fines and Medicare payment withholding can be possible. So high-risk patients have been termed those that have impaired transfer, comatose, malnourished, and end-stage disease, and so other people would be considered low risk. In long-term care, you have what you call your F tags, and F314 is your pressure ulcer investigative protocol, and it really addresses whether the wound was avoidable or unavoidable. But it's really concerned with Medicare compliance, really more so than whether that was a medical determination. But basically, we'll look at, did the facility evaluate the resident's condition and the risk factors that placed them at risk to develop a wound? Were interventions implemented that were consistent with the resident's needs, goals, and again, that recognized standard of care? And there we go back to your policies, your procedures, the NPUAP evidence-based care guidelines that we talked about. We'll be looking at our interventions monitored, reevaluated, and revised as appropriate. For instance, if you were using a pillow to prevent a wound and a heel ulcer developed, did we upgrade that to some type of appropriate heel offloading device? Did we reevaluate and revise as appropriate? And of course, with everything, all our evaluations and interventions, were they documented in a timely way? In acute care, CMS has stated that pressure ulcers are, quote, reasonably avoidable or reasonably preventable with evidence-based interventions. And as you know, hospitals are no longer receiving higher payments if pressure ulcers develop during an admission. And some of the data that I saw that was published in a Hill-Rom national study of P&I data showed that overall pressure ulcer decrease in hospital-acquired ulcers in 2008 and 2009 compared to some previous data. So I really think that we're headed in the right direction. And you know that just every hospital in this country has some type of pressure ulcer team or skin care team or a group together. I know at the Medical University of South Carolina, where I am, we have a multidisciplinary team that's really doing a great job looking at this problem, and I'm sure that every hospital is doing the same thing. The National Pressure Ulcer Advisory Panel, they have also made some statements on avoidable versus unavoidable pressure ulcers in acute care. Their statement was similar to the CMS statement in long-term care, so I'm not going to reiterate that, but they also have made this statement that they were in unanimous agreement that there are some clinical situations when pressure ulcers may be unavoidable. They specifically mentioned that critical care patient with hemodynamic instability, so that when turning and repositioning, maybe their O2 sats dropped or their blood pressure dropped, so turning may not be feasible. If that's the case, then I'm going to be looking at, well, did we step them up to a different surface that would provide as good a pressure redistribution as we can? So we have to think about that. They said that a wound may be unavoidable for a patient who just refuses to be turned, and if that's the case, please make sure that you're documenting that. I would even put in quotes what the patient has said, but I will also document that I've discussed this with him and told him what the problems might be if we don't turn and reposition him. So make sure your documentation is including that. They've also said that patients with skin failure may develop an unavoidable pressure ulcer. Many of you may have heard of the Kennedy terminal ulcer, which is a pear-shaped ulcer that might develop on the sacral ulcer. It develops rapidly and deteriorates rapidly when they might signal that death is imminent. And they call this a Kennedy terminal ulcer. Well, I don't know if this is the only definition of skin failure, but I think that they've gone on record as saying that stating that the skin is an organ, and the skin can fail just like you can have kidney failure, heart failure, liver failure. So I think we'll be seeing more about that in the future. So where does the evidence in a lawsuit come from? How do we determine if a facility deviated from the standard of care? Well, all documentation in the medical record will be looked at, or lack of documentation. So this is why your assessments and documentation are so critical. They'll be looking at facility policies and procedures. Are they evidence-based, and were they followed? Did you provide enough staff to meet the needs of the residents in your facility? Employee records, did we provide education for prevention of pressure ulcers for your staff? May depend upon your recollection of events and certainly the patient and family's recollection of events. What would a reasonable provider do? They will be looking at, did you implement a prevention or treatment plan for heel offloading on that admission who was malnourished, had PAD, was diabetic, and limited mobility following that hip surgery? Did you document the heel offloading device? Were TED hose issues addressed? Did you document that and put them on a pressure redistribution surface? If they're sitting up, do we have a wheelchair cushion? Do we have a turning schedule devised and documented? Do we assess the skin frequently and reevaluate the care plan? Do we have new interventions as needed? Did we assess and document risk factors that might impact ulcer development, like pulses, contractures, comorbidities? Was the physician and the family notified if the wound developed or got worse? Were facility policies followed? Was nutrition addressed? Is pain addressed? As you can see, any pressure ulcer is a lawsuit waiting to happen, so we must be proactive and prevent. I just want to briefly now just mention a little bit as far as topical treatment ulcers, treatment issues for heel ulcers. And the big deal, anytime you have a wound on the heel, the ankle, or the foot, of course, is do they have enough blood flow for healing to occur? So perfusion issues are critical. So if you have a wound and never really, especially if it has necrotic tissue, never do any debridement to that wound until adequate perfusion is determined. You don't want to open that wound up to bacteria if they don't have the ability to heal. So perfusion is critical with wounds in the lower extremities, heel, ankle, foot areas. Making sure that we're providing pressure redistribution with our heel offloading device and monitoring frequently. Again, if they have that black eschar or slough in the wound, keep it dry if possible. Many people may paint it with betadine for antimicrobial control and to keep it dry, or use some type of skin sealant. If the wound does open and you know you have adequate perfusion, then it would be managed just like any other wound by managing necrotic tissue, managing bacteria, and facilitating moist wound healing. If the wound opens up, you're not sure about perfusion, you see drainage, odor, please make sure we're referring these people to a vascular or a wound care clinic for management. So I just did want to mention those as far as treatment issues. The last thing I want to talk to you about is accountability on who's minding the wound. I just want to say that it is everyone's responsibility to prevent heel ulcers. If anyone from administration is in our audience today, you have to know that the buck stops with you. You're responsible for providing resources that your staff needs to manage these and to prevent these wounds. And know that prevention is always cheaper than treatment. Making sure that the staff has the right equipment, the right devices. You're providing education and adequate staff. They need to make sure that or understand that you're committed to pressure ulcer prevention and quality care in your facility. You have to help create that culture where the staff knows that you've got high expectations for ulcer prevention. You've got to make sure that you've got the processes in place that hold staff accountable for pressure ulcer prevention. Are audits being done? Do you have wound team meetings? Are your policies evidence-based? Do you acknowledge your P&I rates? Are you rewarding your staff and units for improved outcomes? I had one director of nursing in a nursing home. She actually would put a little piece of paper under the patient and say, come bring me this piece of paper when you find this. And that way her staff knew that she expected them to turn that patient frequently, and if she didn't get that piece of paper in a timely way, she was down there finding out why. That sets up a culture that they know that that pressure ulcer prevention is an important thing in that facility. So administration is responsible for minding the wounds. Also the professional staff. They're responsible for making sure care plans have appropriate interventions based on their assessments, making sure that the interventions are carried out. Are the assessments done? Are the heel offloading devices in place? Are audits being done to ensure policies are implemented? Is the documentation adequate and timely? Are the interventions evidence-based? You have to also create that culture of caring. You have to have high expectations of your peers and your staff. They will know that you have high expectations when you're checking to see if the turning's done, that the device is in place, and that TED hose are removed and circulation checks done. Make sure you reward your staff for positive outcomes and, again, provide education as needed. What about nursing assistants? This is a shout-out to every nursing assistant listening today because you are the backbone of any pressure ulcer program. I depend on my nursing assistants at the Medical University because these are the people who are doing the daily baths. These are the people that are doing the skin checks, and they're observing are there any new reddened areas. They're the people taking care of the incontinent patient and cleaning up after incontinent episodes. They're taking off the heel offloading devices to assess the skin and taking off the hose to assess the skin. They're the ones doing the turning and positioning and making sure that their patients are eating and drinking their supplements. So make sure that our nursing assistants know how important their job is and how much we depend upon them to help us mind the wounds. Well, what about the physician? Many times I've heard a physician say, well, pressure ulcers, that's a nursing responsibility, and I couldn't disagree more. The physician has to realize that he is the captain of the ship, and he has to do a lot of things as far as prevention and management of these heel ulcers are concerned. I'd like for them to be able to acknowledge the efforts of the staff in their documentation, to acknowledge wound status. Many times I read a chart and there's not even any documentation from the physician that the wound is present or that it has gotten worse. They really need to acknowledge that if there are risk factors present or a physical condition of the patient is going to impact healing. If you know that you've got a terminally ill patient and a non-healing wound, that should be documented. Make sure that the physician is aware of facility policies or protocols and make sure their orders are congruent with them. If you don't think that you can, like a long-term care facility, take care of a particular wound, make sure we get them to somebody who can and refer them to a wound care clinic. Keep current on wound care practices and make sure that the documentation is timely and reflective of the patient's overall health status. A documentation or a note that reads something like poor prognosis, discolored area of heel deteriorating despite all efforts to relieve pressure, no pulses palpated in foot, deterioration probably due to PAD or diabetes. This type of documentation is going to go a long way to demonstrate that the physician is involved in what's going on with pressure ulcer management in a hospital or in a facility. So everyone is accountable, and everyone must mind the heel ulcers and other wounds. So in summary, we have seen that heel pressure ulcers are a major issue across the continuum of care. We've seen that many people are at risk, and we have to identify who they are upon entry into our facility and make sure we're being proactive with instituting prevention protocols. We have seen that heel ulcers can impact quality of life of our patients with pain, decreased mobility. We see an increased risk of limb loss, increased length of stay, and increased cost of care. And I do believe that most heel ulcers can be prevented. I did not say all, but I do believe that most heel ulcers can be prevented. We have to institute evidence-based prevention protocols for our identified high-risk populations on admission to our facility and incorporate those into IT links or our electronic medical record if feasible. Please know that we must suspend the heel with an appropriate offloading device to truly offload and relieve pressure. And we have to know that we all are responsible for creating a culture of caring and accountability. Everyone must be involved in the journey towards zero prevalence of heel pressure ulcers. And that concludes our heel webinar for today. We're going to go into a question and answer period, and please note that you can type any question that you might have into the question box on the console. So thank you very much again for your participation. I'll be glad to entertain any questions at this time. Hi, everyone. I would like to welcome you again. We've got almost 900 sites with us today, so we can see what an important issue we're talking about. And at this time, we do have a lot of questions coming in, and I'll just get right on them. But I would like to make a statement that says the presentation will be available as an on-demand archive version soon after the conclusion of the event, so you will receive an email as soon as it is ready. So that will answer some of your questions. The first question that I have here, it says, how do you estimate the depth of a wound completely covered by a thick adherent eschar? Well, that is an issue that when we talk about a wound that's covered with thick adherent eschar, we're saying this is an unstageable wound, and by definition of unstageable, it says we don't know what the depth is, and we can't visualize it, and really we don't measure it. We might measure length times width, and if you had some type of computer program that you had to put a depth in, I've seen people put like less than 0.1. But really, when you've got an unstageable wound with eschar to skin surface, it's usually a length times a width, and the unstageable part would denote that really there's no measurable depth in that particular wound. The next question is, what is an optimal time to sharp debride an eschar of a heel wound? And that's such an important question because number one is perfusion status. Any time we would have to, before we would do debridement of a heel eschar, we would have to know that you've got adequate perfusion or enough blood flow for healing. Another thing that I might think about is the status of the wound. If you know that you've got a wound with a lot of drainage, fogginess, redness, odor, or some type of wound infection, we would know that that would be an urgent situation, and so immediate debridement and usually sharp debridement would be indicated. Another thing I might think about is site of service and who's doing the debridement. If you're in like a SNF or skilled nursing facility and you've got loose eschar along the edges, maybe we might just clip the loose non-viable tissue away. Or if you've got a bed-bound patient in a long-term care facility or at home and you've got stable, dry eschar, maybe I wouldn't debride it at all. And so it just depends a lot on the wound, but the main thing, as I said, is perfusion status. You would never debride an ulcer on a heel, the foot, or wherever without making sure you've got enough blood flow for healing to occur. Another question, what is an alternative to the TED hose that we talked about in the presentation? Well, you do have your sequential compression devices. You've got your foot pumps. And again, the heel-safe compression stocking that we looked at. And I'm not saying don't use TED hose. I'm just saying that we have to do some critical thinking and looking at those people where we might want to monitor very closely that diabetic, PVD, cardiovascular patient, et cetera. So monitoring is going to be the critical part there. Next, we have a statement that says, I used the heel-free hose on a 51-year-old patient with peripheral vascular disease. The hand of these hoses is lovely. They are soft and smooth and simple to apply. The patient did complain of tenderness at the border of the window the next day. And that, again, is why monitoring is so important. So thank you for that statement. The next question is, what do you recommend for heel offloading in the OR for lengthy surgeries? And I would say any type of heel offloading device that's going to keep the heel suspended for the length of time that you need, whether that's a device that we mentioned, a pillow or what, but something that relieves the pressure and suspends the heel. The next question, are debrided, unstageable, and DTI ulcers considered to be a stage 4 ulcer once they are debrided, or are they considered to be debrided, unstageable, or debrided DTI ulcers? Well, if I had an unstageable, let's say a suspected deep tissue injury, that purple maroon area discoloration on the heel. That would be, as I would stage that as a DTI. In 3 to 4 days, let's say that purplish maroon area is now covered with black eschar, has evolved into eschar. That now would be staged unstageable. And if that ulcer was debrided, and once I debrided the wound, or the wound was debrided, and I had bone exposed, then that unstageable wound would then be a stage 4. So it would just depends upon the wound characteristics, but I would say that you base the staging system on the type of tissue that you observe and the depth of the wound to do some accurate staging. Let's see, the next question, do you suggest painting an intact heel with skin prep? And then another one kind of similar to that is they've been told to stop using moisturizers on intact heels, instead to use a skin care type product. Well, whether you want to moisturize healthy intact skin daily with a moisturizer, whether you want to paint it with a skin prep or a skin sealant type product, that would more or less dry it out. The main thing I want is somebody looking at that heel every day and monitoring what the heel looks like. Of course, you don't want too much moisture, because that moisture warmth friction, those are the characteristics that are going to lead to some tissue damage perhaps. But I don't want you to think that you can put either a moisturizer or a skin prep on a heel and prevent a wound. You still need heel suspension. You need that pressure relief. Okay, another question. It says, when to drain a heel blister? Well, if I've got an intact blister that's pretty stable, I might leave it in place because it doesn't really need a dressing on it, and it's acting as its own dressing, the epidermis is, because with that blister you've got separation of the epidermis and dermis. But if it was fluctuant and I know that it was going to break maybe during the night and then leave an exposed wound possibly with no dressing on it, I might be a little more aggressive to it and you can insert a syringe in with a needle and aspirate out any fluid, or you could prick it and let the fluid out. And then again, you would have to cover that wound if you lost that epidermis, because you don't want to leave exposed dermis because it will dry out. So again, that kind of depends on different situations. Let's see if I've got any more questions here. What is the acceptable treatment for a stage 2 heel ulcer? When you have a stage 2 wound, you have a partial thickness wound with dermis exposed, and that would be just to facilitate a moist wound healing environment as far as topical treatment is concerned. And there are lots of different dressings that would be appropriate, but again, remember that you still need to suspend that heel, relieve the pressure while you're facilitating a moist wound environment with various dressings. And again, that might depend upon the site of service, the characteristics of the wound, but basically any dressing that would facilitate moist wound healing to cover that exposed dermis would be something, whether that's a film, even a foam, or some type of dressing, just to meet the characteristics, again, depending on how much drainage you had, etc. Let's see. The use of a device called Heels Up causes patients to have loss of lower leg muscle as the lower leg is elevated on the device suspending the heels. I'm trying to see exactly, and it says help there. If you're, the only thing that I can say is you do need to support the calves. You need to suspend the heel. So I think you have to just kind of do whatever you can do to meet those, and you want to gatch that knee a little bit. You don't want any pressure on the nerve or the vessels in that lower leg taking blood flow to the heel. But again, it's the monitoring that's going to be important. The important part there. Is there any one heel particular release system that you feel works best? Well, I have to say that I have been a DM user, the heel lift user for many, many years, and have found that to be very helpful for the patients that I've taken care of. However, there are many other products on the market that can do probably a very fine job also. I haven't had a lot of experience with a lot of them, but the main thing is, what are you trying to accomplish? We went over a lot of the objectives that you're looking for, and then look for the device that best meets the objectives that you're trying to create. Let's see if there's some other questions here. What does the clinician do that sees an unstageable heel, DTI, along the medial aspect of the foot and has severe foot drop? Well, again, you're going to have to use some type of device that is going to address the pressure on that particular area and anatomically keep the foot in the right position. And there are many, again, like I said, there are many devices out there that for us to use, but if you can't find one that meets your particular situation, what I do is usually get my PT or OT involved to see if they can come up with the development of some type of device that's going to be able to meet the needs of that particular situation of that particular patient. Let's see. Hello, I am a nursing instructor, and I was wondering if saline moistened dressing changes are still okay to use. This has been a debate among faculty. Well, first of all, as a wound care clinician, I would say that we try to stay away from saline moistened dressing changes for several reasons. First of all is the pain that is caused if the dressing is allowed to dry out, if the gauze is allowed to dry out on the wound. They did a survey among thousands of wound care clinicians, and they said that the most pain that a person would encounter during is the removal of the dressing. And when the dressing was adhered to the wound, this causes a lot of pain. So we know that saline, and you don't have wet to dry, you've got saline moistened dressings. If you can keep them moist to prevent them from drying out, that's one thing, but that is also very labor intensive. And the more labor intensive you get, the more costly it's going to get as far as nursing time, etc. So I would have to say that the standard of care for most wound care clinicians is to really stay away from gauze and saline for those particular reasons. There's just a lot of other better modalities, better ways to go to facilitate moist wound healing, because as I said, the saline gauze does dry out very, very quickly, adheres to the wound bed, causes pain, also can damage new healthy granulation tissue, and also can leave remnants of gauze tissue in the wound, which will increase or prolong that inflammatory reaction, that inflammatory period that we have. So to make a long story short, I would say let's try to stay away from gauze and saline and do some other dressings that will facilitate moist wound healing. All righty. Let's see another one. When wrapping legs with ACE wraps, do you suggest including the heels in the wraps? Well, the only time, I don't really use a lot of ACE wraps, to be honest with you, but anytime if I'm doing compression dressings with some type of compression bandaging system, we always include the heels. And so I would say that the heels should be included, because if you don't, that's where you're going to get edema at that particular area if they're not included in the wrap. And even if I'm just using like a Curlex gauze to to hold a dressing in place on the foot, I will usually include the heel also in that dressing for that reason. Okay. Let's see if there's anything. Let me hit refresh and see if there's anything else. Let's see. Any thoughts on how to get physician engagement? Well, that's a whole nother, that's a very big topic, but I think that it's key that the physician realize that they are the captain of the ship, that the buck will stop with them, and it should stop with them, and they are an important part of the wound care team. And I think they have to buy into that, and I think most physicians are quite willing to do that and want to be on the team. So I think that we just have to continue to let them know how important they are, that making sure that they've signed off on any kind of protocol or your policy, your standards of care that you're using in any facility. And legally, they have to know that the buck will stop with them, and ignorance of what's going on with the wound or whatever is really no excuse in a court of law. So we do need physician involvement, and again, it's just going to be a continued effort, because I really do believe that most physicians do want to be involved and in what's going on with their patients, and most of them do know that they are responsible for everything that does go on. Let's see. Do we have a copy of the PowerPoint presentation? I think you can download a PDF of this presentation, so that's the answer to that one. Let's see. Is betadine still the most common treatment for heel ulcers? Well, betadine can be used and is still used as an effort to keep the wound dry. Usually, if we're painting it, the heel ulcer that's covered with eschar is the one that we're using the betadine on for some antimicrobial control and to keep the wound dried out. Of course, we would never use betadine on an open wound that you think with healthy tissue that you're trying to heal. Okay, so I don't see any new questions. Again, I want to thank you, and I would like to thank DM Systems for their sponsorship of this webinar, and HMP for their help with it also. And thank you very much for your participation. Goodbye.